Neither of you is a depressed person.
None of us is a depressed person, that's right.
Welcome to the next episode of Endoscopy Essentials, and welcome to Barham Abu Dayyeh from very recently Los Angeles.
That's right.
We'll get to that in another podcast. So we want to deep dive into gastroplasty,
Yes.
Which is a new procedure. And what's your personal history with it?
Well, thank you, Thomas, for the invitation, and it's a pleasure to be here discussing some of these innovations in our field. Gastroplasty is one of them. So the history as it pertains to me, we've always had this vision that the GI tract holds the key to not only manage but potentially modify metabolic diseases like obesity and type 2 diabetes. And we thought the only way to scale these gut-based therapies is to use endoscopy. So it made sense to us, to many of us, many years ago, to start exploring that frontier. How do we get a camera to do major gastric remodeling? It was a crazy concept back then, and people thought it's not possible. So, but my journey with it started with me and Christopher Gastaut at the Mayo Clinic. Around 2010, 2011, Chris Gastaut was starting to explore doing this in the lab because we did not have access to do it in humans yet because there's no data. So he embarked on a series
and a big frontier from the surgeons, right?
Big frontier from the surgeons, that's right. So we had this new device called the Apollo Overstitch back then. It was in its early rudimentary form, and he took it.
Developed by an American group.
Developed by an American
guys, right?
Yeah, exactly. Yeah. And then these are lessons in innovation. So we tried it, and I still have these lab books. We tried it in pigs, and it did not work. Pigs' stomachs are very thick. Technically, it was very challenging to have a gastroplasty construct in a pig. The stomach is thick, the sutures were not able to approximate this big, huge, humongous stomach. So of course we got depressed and we said that's not gonna work. So then we went to say, okay, maybe dogs, better model.
Neither of you is a depressed person.
None of us is a depressed person, that's right. So we went to dogs, dogs were better. So it gave us a signal that we could do this safely because we do these gastroplasty constructs, not ideal yet, but the animals will be doing okay. Then Chris said, well, let's do some in baboon. But nonetheless, 2011, we had enough safety data. We still have not optimized anything. And we applied for a early feasibility human protocol. The IRBs, of course, looked at it, says big unmet needs, make sense, good enough data, and the device that's already available in the market for tissue approximation. And we embarked on the first clinical trial with this. Remember the first case, me and Chris were doing it. We alternate. He does one suture, I do one suture. And nurses would bring pizza to the room. It was about 4 hours. But these are the learnings that you have to go through with these. Second case became 2 hours and a half. Case number 5, we start saying, okay, where's the path to do this under an hour? But still, it was still cumbersome, many sutures. And we end up, that protocol enrolled the first 10 human feasibility cases, published in GIE as innovation section. And at that point, we struggled what to call this procedure. And we called it endoscopic sleeve gastroplasty, an alternative to sleeve gastrectomy. And that triggered, it was provocative back then, triggered a whole slew of how we push this forward.
It's all about good title in that paper.
It's good. Right? It's all about good title, and now it's like sleeve gastrectomy surgery was doing this globally. And everybody's like, oh, you could do an endoscopic version of it. But we were not intending, the name was descriptive, it's endoscopic. A sleeve, we're creating a sleeve construct, and gastroplasty, we're not removing any parts of the stomach, we're just imbricating it from inside.
So complication-wise, I think the stomach is a strong organ. So perforation was probably not your primary fear. So what were you afraid? Vessels outside or the esophagus, on passage?
Of course, we did not know any of that back then, right? You assume that the worst.
You go into something and
you assume that exactly.
Fears, right?
But knock on wood, after case number 5, we said, okay, we could do this without major catastrophes. Patients were having a lot of symptoms of accommodation, but we learned how to manage these, and we became better in them. And fast forward, now more than a decade later, tens of thousands of procedures, traditionally under 45 minutes. Very straightforward and with a safety profile similar to upper endoscopy with the EMR. So came a long way.
Right. And you have data, you have a study, high-ranking publication, everything. So it's kind of established. What about reimbursement? That's a problem worldwide, maybe more in Europe than in the States. How is it handled here?
Well, it's the talk about reimbursement goes beyond gastroplasty. It goes in innovation in our field in general, and this is one of my life missions, is to improve cures to patients in a time frame that will help our patients. Right now, it will take an innovative, value-added procedure or a device more than a decade. And more than $100 million to make it through the cycle. Once it makes it through the cycle, it will take another 5 years before it becomes paid for. And by the time 15 years pass, the technology itself has been disrupted or no longer relevant to patient care. So everybody loses. So to me, one of my life missions is I'm going to try to push my envelope through my position being in innovation and in business development and what have you, to cures to patients within 5 years or less. And I think this message is resonating with regulators, resonating with the government. But what we currently are with, a randomized trial for endoscopic sleeve gastroplasty happened, published in The Lancet. That provided level 1 evidence. There has been clinical evidence that is not randomized and from different forms.
Like long-term
and prospective and retrospective and some comparative retrospective data. So in total, the dossier that went to the reimbursement story, so now you get FDA approved, you have to go argue for category coding, or what we call category 1. It requires, there are certain criteria, including having randomized trials in visible journals or reputable journals, including clinical adoption of the technique, including unmet need and other things, but these are the 2 big ones. Evidence,
which sounds okay.
Which sounds okay. And it's we went for that CPT code last year, and we got the CPT code. So now the procedure has a established category 1 CPT code. Just to put in perspective, we have well-established, much older procedures in our field, like ESD, with no category 1 codes yet.
Okay, so you can be satisfied.
We can be satisfied. We get a middle ground.
Life mission accomplished, but not quite.
Exactly. And the good thing is that CPT code is going to live with where we need to be living. We're living in the world of surgical endoscopy, and the reimbursement have to reflect that. Otherwise, adoption is going to be limited. So that CPT code is going to be living in this category. It's going to be under restrictive gastric procedures, where the bariatric surgery lives more or less. And this, of course, is not bariatric surgery. So now it will go effect in next year. And then hopefully adoption is going to uptake.
Right. That leads us into performance and preparation type of thing. You said it's replacing surgery, or it is surgery. Is it done under general anesthesia? So you have to do that or not? Because that's our ongoing discussions. Endoscopists try to avoid at all costs general anesthesia, and then we're complaining about low reimbursement. So what's the status?
So Number one, it's not competing with surgery. That's where it's a message that's probably not resonating too much. That's why there's a lot of confusion. Is it surgery? Is it endoscopy? It's a new category for weight loss. And that category has unique value proposition that has elements that overlap with modern medications and have elements that overlap with bariatric surgery in one sense or the other. Where it overlaps with medication, you could view this as screening colonoscopy. You go to your gastroenterologist, you get screening colonoscopy, and you are fine for the next 3 years, and you have decreased your risk of colorectal cancer. This could be a procedure that is done outpatient. Now, 45 minutes, very safe, almost as safe as screening colonoscopy, and gets you the weight loss that a medication would give you over the 3 years horizon, but without a weekly injectable, without the needing to be compliant, without the cost that comes with medication. So when you look at it that way, it's competing with even medications because it's one-time endoscopy, safe, anatomy preserving, lasts you for 3 years or more, and it is more cost effective than a medication strategy. So in that side, you look at it as here's the combined and here's the unique value proposition. On the other hand, surgery is definitely more durable and definitely more effective. But a lot of people, barriers to access to surgeries, they do not want to lose the organ. You don't want to remove the stomach in that process. And that becomes a unique value proposition compared to bariatric surgery. So it's neither surgery nor medication. It has value that makes it more competitive with either and more scalable, but it's in the category of its own. Yes, it's general anesthesia should not be a barrier. I've done this procedure without general anesthesia. Propofol sedation have came long ways. The concept is it's not like you're doing something that patient is going to have massive bleeding or aspiration. You just need the patient to be quiet during the suturing process, and propofol does the job very well in a 45-minute procedure.
On the other hand, and now we get into a different area of strategy, I think general anesthesia team should be part of an intervention endoscopy of it. And because a lot of things we're doing in the esophagus, etc., I think the surgeons would never ever do without general anesthesia. And you can view it from both sides. So I would rather favor it, I think.
I'm always in for a general anesthesia, but if it becomes a barrier for people, then it's a good to have, it's not must have.
But there is also an increased risk of sedation with propofol in obese patients, so that many people out there in private practice are very reluctant to do it under propofol or whatever, or so patients have to suffer through an unsedated upper GI endoscopy. So that's one of the sensitive issues, right? But going back to a broader horizon about indication where that fits in, I think you have a nice slide to show us. This concept, because there's also the huge market of medication, huge hype at the moment.
Absolutely. So, I mean, if you see the slide in front of you, this is looking on the x-axis, invasiveness of intervention, on the y-axis, efficacy and durability. For decades, we had this dichotomous, either lifestyle intervention, which we knew they were not working, or bariatric surgery. Now we have medications, and medications are definitely a welcome addition to this armamentarium. They are doing a phenomenal job in having people lose weight. They're effective and they're safe. But medications have issues in that they are not modifying the disease. Many people stop them within the year after they initiate them, and the weight comes back. And
I think there was a recent paper saying that 65% of patients drop it after a year.
Exactly. So compliance and long-term use and cost are all limitations of the medications.
I mean, safety, do you expect some kind of back after a few years, like with PPIs, that all of a sudden from dementia to everything?
It's not dementia. We have the obvious. You're driving the beta cells of the pancreas strongly with super physiologic dose of hormones that have effect. And so we know that it's been clear now that there's increased risk of retention of gastric content and canceled procedures in endoscopy. Though that risk did not translate to aspiration risk, but it's based on the literature, it's there. Of course, there is contradictory reports on pancreatitis, but I believe pancreatitis is a real entity. It makes sense. You're driving the beta cells and the pancreas strongly, and you might see that. Whether it's also related to macrolithiasis and the weight loss, it's still to be teased out, but I think pancreatitis is an entity. I'm not sure how common, but it's an entity that continue to evolve. And of course, these are physiological hormones that are not designed to stay in the bloodstream. So we're making them linger in the bloodstream for weeks, and they will drive not only what they need to drive, but there's receptors for GLP-1 and GIP all throughout the body, in the brain, thyroid, all throughout. And therefore, we do not know the risks of long-term malignancy. Right. That is something that needs to be figured out with after decades of exposure, because it's not
right. That's good. Why I was citing PPIs, because everybody got it in the early period, and then only after years and years. Even if mostly unsubstantiated, but that's a difficult area to find out, right? The rare side effects. Okay, so the medications won't fill the entire gap.
They will fill a gap, not the entire gap. Then you come with these EBMTs, endoscopic bariatric and metabolic therapies, and hopefully we'll talk about the small bowel therapies at some different episodes. But these have a unique value proposition. The weight loss is similar to the modern medication. We cannot claim that we are doing better weight loss than the medication, because we're not. It's similar to the modern medication. Even some of the newer medications are even better. But the idea is you keep the stomach. You're not exposing the system to long-term drug exposure. Tolerance is after the accommodation symptoms in the first couple of days seems to be better than some of these modern medications. And compliance which I think is important. People underestimate how non-compliant patients are with medications. Yeah. Patients do not like to take medications. And compliance is minimized because...
And studies are in an artificial environment. It's closely monitored by the patient.
Absolutely, absolutely. So that becomes the unique value proposition for endoscopic bariatric therapies. And the exciting part now is we're embarking on this era where next generation is we are gonna replicate bariatric surgery, but maintain the safety of endoscopy. So the key becomes scalability. So we need to make a dent in that disease, durability, and value. And value comes from disease modification. And why do I'm very excited about this, because this is a really nice paper that just came in the New England Journal of Medicine, that you look at how body weight or adiposity and metabolism is regulated. And if you look at all the images, just simple look at the images, you could see that the GI tract is the orchestrator of that orchestra. And it's not only the orchestrator, it's the only hope for disease modification. That means not management. Management is like somebody has pneumonia and you give them Tylenol for the fever. You could get down the fever, but the pneumonia is still there. Disease modification means that we are reversing the pathophysiology to decrease the burden of medication, not to continue to escalate. And I think it's pretty clear, and we could talk about this evidence at later episodes as well, because there's very profound evidence suggesting that the GI tract could modify, not just manage. And so when you talk about gastroplasty and how it could manage, you could see that there's the stomach, and the stomach is good for regulating human appetite through the process of accommodation and emptying. Then the small intestines is good to regulate the glucose homeostasis and the metabolism and inflammation. And as you could see, so if we looked at the stomach for the gastroplasty, which the stomach is, we could alter human appetite through satiety and satiation. And I'm sure your audience have seen different flavors of this, but this is how this is done. I mean, when I was in training, to tell me that you were gonna sew about 1.5 meters away with small, tiny instruments like this inside of the stomach, I will tell you, sign me up for interventional GI. But nobody thought that we could ever do this. But now it's a reality. With high fidelity, we go on the greater curvature of the stomach. We put continuous sutures that are full thickness. And what you see, Thomas, here is with every sequence, you are doing two things: shrinking the length of the stomach and tuberizing the greater curvature, which impacting the two important regulator of appetite, satiety and satiation, through the process of accommodation and emptying. So it's not just restriction, it's truly impacting human appetite through these processes. And we looked at that. Actually, I think you reviewed this, or you were the editor to GUT when that happened. This paper is we used sophisticated MRI with gadolinium labeled meals to look at how it affects the emptying and accommodation of the stomach. And you could see the imbrication of the greater curvature. You could see a shortened stomach, but you could see that food is delayed until it mixes to the antrum, but the antrum is contractile. That means you have delaying gastric emptying, but no gastroparesis. Because once it makes it to the antrum, it exits, and you could see that the accommodation of the stomach is significantly altered. So it's not just hypothetical that it affects these critical physiological pathways. Now we have published data with sophisticated physiological testing showing that concept.
Functional MRI is underused, unfortunately.
It's underused.
It's a fantastic technique, but radiologists have limited interest.
It's cumbersome, expensive,
yeah.
But you could get unprecedented look at the physiology and the anatomy as well.
But going back to medications versus endoscopic therapies, what's your vision, or what will be the next studies of a combination?
Yeah. Well, of course, we love to talk about combinations, but reality is it's all about value to the healthcare system. And given compliance issues, in reality, combination is although it makes sense, it's not going to likely be the first line approach to these things.
That's right, but I don't speak of a continuous therapy plus gastroplasty.
Yeah.
But maybe you do the medication before or in the period afterwards. So where would it make most sense?
It makes more sense that now we look at disease pillars rather than pyramids. Pyramids means you start with this, you go to that, and you keep escalating. Disease pillars mean that you start with the treatment that appeals to the patient, and the patient could be compliant with it, because we said medications could. Endoscopy could be as safe as medication. It's the safety issue is not and more cost effective. So then you start with the one that appeals to the patient, and then you maximize that one first. And you extract as much efficacy as possible. Many people, the literature would say 30% will do fine over lifetime. Because they have learned how to adapt to this. That was the catalyst for them to get them back on track, and they are on autopilot. You don't need to worry about them. 30% will struggle, and the struggle is mostly could be mitigated by re-engagement with the healthcare team, with healthy living. I don't call it diet and exercise because nobody wants to follow diet and exercise. People want to live healthy, so they could follow.
They have tried before.
They've tried. But re-engaging them with simple things sometimes gets them back on track. There's 30% that are either non-responders or really have gained all the weight, so it was not the right procedure for the right patient or the right medication for the right patient. For these patients, you escalate care or you add something different. So I think that's why, and we're gonna learn about the physiology a lot, and personalized medicine and precision medicine, and how to start where and how to go. But I am not an advocate of throw the kitchen sink, because because we will wreck the healthcare system.
Yeah, that's right. On the other hand, do you think there's a motivational issue? So the patient loses weight with one technique, he might want to do the other, but initially not?
Absolutely. I mean, we're busy professionals. I have acid reflux. I cannot remember taking my PPI. And not because I don't want to take I just don't remember taking it, and I'm too busy to remember it. A lot of people say, I'm not going to be able to be compliant with medication. And no matter how effective it is, it's not going to fit in that paradigm. Therefore, endoscopy is a very valid solution for them. So yes, patient motivation and patient drivers is going to be an important part. That's why I do not like the pyramid. I love the pillars, and we should be counseling the patient across the pillars. Same for bariatric surgery. If I have somebody who's diabetic with BMI 50, I'm not offering them medication nor endoscopy with wide gastric bypass.
Right. Is there anything you would like to combine with gastroplasty, like funding ablation, or to maximize effect? Of course, we don't have enough data, but what's the vision?
Yeah. Well, in this DDW, we just presented a blinded randomized trial where we did APC ablation with gastroplasty versus no APC ablation and gastroplasty. And the results are interesting. We used functional MRI to look at the construct durability. That was the primary endpoint. And we also use gastric emptying for scintigraphy, and we did endoscopy on everybody. So to give us all modalities to look at the answer. It seems like adding the ablative techniques to the stomach could improve durability of the proximal construct, not necessarily the distal construct.
As expected?
As expected. Yeah. Though the weight loss at 20 years was similar between two groups.
Okay.
And now we're in the era where we're hitting 20%. So both groups, one got 22% and one got 21% at 1 year. We've seen that there's divergence in responders rate, those percentage getting more than 20%. So we asked the IRB to extend follow-up for another year. So we reported in another year if there's this pattern of divergence continues, long-term effect. But we'll see.
Very interesting.
Yeah. But my other interested combination is different mechanism. So you have the weight loss that comes from gastric restriction, combine it with same session, not different session, regenerative techniques of the small intestines to get to the insulin resistance and the inflammation part of the equation.
Okay. Rather than adding two similar techniques, combining two different techniques.
That's right.
Okay, wonderful first episode. Thank you very much. Thank you for watching, and we'll be back with a patient and gastroplasty.